Hello and thank you to all of you for joining us for the third webinar in this series. The series is called From Pandemic to Progress, Building Capacity Through Global Surgical, Obstetric, Trauma and Anaesthesia Systems. This webinar is entitled Trauma, Who Cares? The series is presented by the G4 Alliance, the Global Alliance for Surgical, Obstetric, Trauma and Anaesthesia Care, along with the Global Initiative for Children's Surgery, known as GICS or GICS, and the Program for Global Surgery and Social Change at Harvard Medical School, along with additional partners for each of our 4 webinars. Today's webinar is presented with the support of the Primary Trauma Care Foundation and the Australasian College of Emergency Medicine. While today's speakers will be speaking in English, as I am, you can select Spanish or French to listen to by selecting the interpretation icon. For most of you, it should be along the bottom of your screen or else at the top. Click that and then select the language you wish to listen to. The interpretation will be simultaneous. The interpretation into French and Spanish is generously supported by Operation Smile and Smile Train. Thank you both. My name is Charles Clayton. I'm the Chief Executive of the Primary Trauma Care Foundation here in the UK and worldwide, and also the a member of the G4 Alliance organization, and I'm a member of the G4 Alliance Permanent Council. We have an exciting panel to hear from, and you'll be able to pose questions to the panel. To pose a question, please select Q&A on your screen and type your question there. If you'd like to make a comment rather than pose a question, please put your comments in the chat feature by selecting the chat icon. Comments and questions will be visible to all the attendees. Remember, questions go in the Q&A and comments in the chat. I will introduce the speakers one by one, but somebody else is going to be on the screen in a moment, joining us, who may help us with answering questions, and his name is Dr. Myron Roll. He's a Bahamian American, an American neurosurgery resident at Harvard Medical School in Massachusetts General Hospital. You might know him because he played college football at Florida State and was drafted by the Tennessee Titans in the 6th round of the 2010 NFL draft. He was awarded a Rhodes Scholarship and studied at St. Edmund Hall, Oxford University, where I'm speaking to you now. He was here in the 2009 to 10 academic year to earn an MSc in medical anthropology. And by the way, he was chosen as the 2nd smartest athlete in sports by Sporting News. I'll leave it to you to guess who came first. Our first speaker today is on our panel is Dr. Mandip Kor. Dr. Kor is a trauma, GI, and hernia surgeon. She serves as Director for International Affairs for Abdominal Wall Reconstruction Surgeons and as a volunteer for instructor training in the field of trauma, including the Primary Trauma Care Foundation in India. She is a member of the Indian Association of Gastrointestinal and Endoscopic Surgeons and the Obesity Surgeons Society of India. She has worked in various trauma centers in India and the UK, and Dr. Kor will set the stage for us by speaking about the worldwide trauma issue. Dr. Kor, what is the worldwide trauma issue?
Yeah, I've unmuted myself. Hello, good morning, everyone. Thanks for this opportunity today to discuss the trauma scenario with this esteemed group. Being a trauma and a GI surgeon, I deal in trauma day in, day out, along with operating in the theaters on trauma patients, receiving code reds in accidents and emergency. I'm also involved in teaching primary trauma care and ATLS to doctors. Today here, I present the scale and trends of trauma across the globe. On the current slide today, if we look on the leftmost graph, we find out that every year 5 million people die because of trauma of various kinds. To bring this number into a perspective, this is equal to the whole population of Costa Rica. That means every year, one whole country is wiped out from the face of the earth just because of trauma. More people now die in road traffic crashes than they die in HIV, AIDS, tuberculosis, and malaria, all put together. And well, it doesn't stop there. There are around 40 million disabilities per year which are caused by trauma of all the major and minor form. And along with these impacts, another major cause is the financial loss, not only of the families involved in the trauma, but also of the financial loss which a nation has to bear. It is estimated that 1 to 4% of the gross domestic product of a nation is spent in the management of these trauma cases. To highlight, for many nations, this loss is actually more than the GDP that they spare for healthcare overall. So to summarize the slide, loss and size of trauma is significant. Let's move on to the next one and look at the various causes of trauma. If we look at this pie chart, road traffic accidents are the leading cause of death at 23%. They claim about 3,700 lives per year. Every 24 seconds, someone dies on the road. One alarming fact, by the time I finish this presentation of mine, 20 people would be dead on the road and 180 other hospitalized with severe injuries. Now this is concerning. Let's move on to the next slide and double click on the road traffic injuries and impact when we look at the age group. Road traffic injuries are the second most common killer in children after respiratory diseases. For youth, these are the main cause of death. For the most productive age group of 30 to 44 years, these are the third most common killer. Now it puts a huge burden on the financial health of the nation and the families. Households are driven into poverty with loss of the breadwinner or an added burden of caring for a disabled person. And let's not forget the burden it puts on the insurance companies and the legal system. Current statistics worldwide, they show 900,000 deaths by COVID, and it is a pandemic. I wonder what would take road traffic accidents to be declared a pandemic and appropriate measures to be taken. If we move on to the next slide, we see that for every one person killed in the road traffic accident, 9 other are hospitalized. And then there are 88 other who are treated in emergency department on day case basis. All this means that money is spent in millions that could instead be used in building infrastructure or treating cancer patients, barring a few one. Cancer, unfortunately, is not a preventable disease. Now let's look at the next slide, which shows the gender-based distribution. If we look at this bar graph, we can see that overall of all the trauma cases, men are killed more than women. And if we look on the bar graph on the extreme right, we see that the road traffic injuries kill far more men than the women. Overall, understanding the scenario, the breadwinner and the economy sustaining age and gender of the population, they are most at risk, simply because they are out on the roads more often than others. Moving on to the next slide, we see that the challenge is much more worse in the low and the middle income group countries. These countries are anyways resource poor. In a low and a middle income group country, for every road traffic accident, 3 times more people would die of a similar injury as compared to the high income group countries. In LMICs, there are 1% of world's total vehicles, but 13% deaths. And that is because of poor road infrastructure, poor pre and in-hospital trauma care, and kind of missing rehabilitation programs. Now it costs approximately $65 billion. This is the amount that these countries receive as development aid, and more than the total GDP that these countries would normally spend on healthcare. Now, while the high income group countries, they have the statistics of death and injury have plateaued over the last few years. Unfortunately, there has been no reduction in the accident or death rates in the low and middle income group countries. Let's move on to the next slide. The key point that I want to highlight in this slide is that trauma is preventable. We need to understand what is slowing us down and what are the steps that we can take to mitigate that. As I understand that, the problem is two-pronged. One limb is the infrastructure, law enforcement part of trauma, and the second part is the medical care, which includes pre-hospital, in-hospital trauma care and rehabilitation. From my understanding, while the government should take road and vehicle conditions seriously, implement stronger laws for betterment to prevent road traffic accidents, at the same time, adequate attention should be paid to pre and in-hospital trauma care and rehabilitation. We as a Primary Trauma Care Foundation are doing our bit in teaching and training the poor resource countries about trauma care. We would urge governments of the various countries to take trauma care seriously and look at law enforcement along with the medical care. I'm sure we can reduce trauma and nullify the effect with a proper action plan. This brings me to the end of my presentation. To summarize, trauma has a significant impact worldwide and needs adequate attention of various world leaders. Thanks a lot for your time and attention today. Please let me know if there are any comments or questions. Over to Charles now.
Thank you very much, Dr. Kor. You set the scene there, big problem globally. And I want to encourage all of you listening to this webinar to send in your questions using the Q&A box, and we will attend to those. Let me pass to you, Mandip, one I've received, which says, you mentioned the trauma numbers globally. The question is, what in your opinion is the reason for the persistently high trauma numbers in low and middle income countries?
Well, I think the acceptance of the fact that, the trauma is such a major killer. I think we are in denial that, it's a routine thing. People go on road, they meet with accidents and they die. This denial, I think, is the major reason that, the middle and the low income group countries, they have a persistently high trauma numbers. Most of these countries will not participate in a trauma registry, that is an international registry. This indicates how seriously, the whole situation is taken in these countries. Like COVID, as soon as we recognized that there's an issue, we took steps. Every country has participated, taken steps to control, spend money on all that. Trauma has never been seen such a major killer. I think this is the major reason. I would not call money as a major reason, honestly.
Okay. Let me ask another one, which I'm aware of. Let me just give me a second to check on the Q&A. A question just arrived that says, has the role of driver's education in reducing road accidents been studied in the LMICs?
Yeah, well, if you look at the data which is provided by the World Health Organization, and I refer to the data of India, my own country. Yeah, well, education will play a major role once it is recognized as an issue. So education of the drivers, looking into the condition of roads, vehicles, all that will have a major impact.
Good. I'm sure we'll hear more about that from Nigel Rossiter, who's going to speak in a few minutes on prevention and rehabilitation, in fact, as well. So meanwhile, another question just arrived, Mandip, and it's this, the global problem, I'll read to you, the global problem of preventable trauma is well known, but the ways and means to prevent, treat, and rehabilitate has not been addressed. I'm just reading this question live, so I'm going to defer this one to the end because I'm sure Nigel will want to speak to this one. So from our questioner, Ram Shah, we will come back to you in a few minutes. In the meantime, I want to pass on another question, Mandip, to you finally, just enough time for this, which is, apart from road traffic injuries, what are the other kinds of traumas that are increasing worldwide? And may I just ask you to comment also, Mandip, on what you're doing about head injuries in injury, which I know is a big issue there. Have we lost Mandip? I think we've lost.
It seems like we have.
Oh, the joys of working on these systems.
From halfway around the world that these things happen.
Well,
Why don't we go on to the next one, Charles, and we can always return.
I'm sure Mandip will arrive and rejoin us, and we can ask her more questions when she does. So our next speaker is going to speak. The next speaker is Dr. Georgina Phillips. She's an emergency physician at St. Vincent's Hospital in Melbourne, Australia. She's a member of the Global Emergency Care Committee for the Australasian College for Emergency Medicine, that's ACEM, and a liaison representative for the Pacific Regional and Solomon Islands for that college. She is a board member of the St. Vincent's Pacific Health Fund in Australia, of the Primary Trauma Care Foundation here in the UK, and the Australian College of Emergency Medicine in Australia. She's also a PhD scholar at Monash University in Australia and section editor for the Emergency Medicine Australasian Journal. Welcome, Dr. Phillips.
Thanks, Charles, and thanks, Mandip. And hello, everybody. Greetings from the Western Pacific region. I'm going to focus on the solutions of strengthening pre-hospital and facility-based emergency care for the injured patient, using some images from Pacific Island countries to illustrate the issue. We know that injuries occur everywhere, all the time, from individual road accidents to large-scale mass trauma and disaster events. Trauma consumes enormous resources wherever you are, but it is wrong to assume that providing emergency care for injured people is too expensive or only a luxury item for rich countries. Emergency care systems can be built and are cost-effective in all settings and can prevent disability and save lives for victims of trauma. We know from Mandip that fatality rates in low-income countries from road traffic injuries are 3 times those of high-income countries. But recent modelling shows that potentially over 50% of global deaths can be prevented by safe and effective pre-hospital and facility-based emergency care, and millions of these are trauma-related preventable deaths. The COVID-19 pandemic has shown us that emergency care is essential for universal access to the healthcare system. As recognised in the 2019 World Health Assembly Resolution 7216, emergency care is the integrated platform that links the community with the broader health system. And for people with acute injury, and all people with any acute condition, an emergency care system delivers accessible, safe, and timely healthcare across the entire life course. Next slide. So, for the injured person, what is a safe and effective emergency care system that will save their life or prevent disability? The WHO provides this terrific infographic that explains the components of emergency care within a systems framework. Emergency care is provided at the scene of an injury by trained first responders giving basic first aid, who call for help and can receive advice using a known regional or national emergency call number. Help is dispatched to the injured patient, where emergency care is safely delivered at the scene and during transport to a healthcare facility. There is a separate driver and healthcare and trained care provider who use basic equipment and simple knowledge and skills to perform life-saving actions for the trauma patient as they are en route. The injured patient arrives quickly and safely at a facility, perhaps a clinic, a district or urban hospital. There is an emergency unit set up for trauma reception, assessment and management, and equipment for airway, breathing and circulation resuscitation, spine protection, limb splinting and pain relief. The emergency care providers use their skills and knowledge for rapid life and limb-saving actions. They are well trained, they're well staffed over 24 hours, and highly motivated because they know their work makes a difference. There are effective processes for patient triage, data collection, checklists and documentation, and rapid referral to the operating theatre, the wards, physiotherapy and allied health, or discharge home for those with minor injuries. Overall governance ensures that the providers are protected by law, that emergency care is recognised as essential to universal access and is embedded within the health system, and that emergency care systems are integrated with public health and surge event, mass casualty or disaster responses. Unfortunately, globally, most pre-hospital systems are poorly developed. Many transport options for the injured patient, like this one, are inadequate and high risk. But building a pre-hospital system is feasible and affordable. According to modelling from the Disease Control Priorities 3rd edition and the WHO, providing community ambulances and training pre-hospital providers is extremely cost effective. The cost per life year gained for staffed rural ambulances is estimated at under $300. For staffed urban ambulances, under $100, and spending $7 per year of life gained for trained lay first responders and paramedics is surely great value in any context. These costs are low compared to the cost per life year gained for the provision of antiretrovirals for HIV. Immediate life-saving care for the injured patient is critical when they arrive at a health facility, but in many parts of the world, the emergency unit is understaffed, poorly equipped, badly designed, and chaotic, with no clear processes or leadership to organise effective care. But there are solutions to building cost-effective and context-appropriate facility-based emergency care systems. The WHO provides a suite of tools that can help governments work with key stakeholders to assess their emergency units using the health system building blocks and determine priorities and action plans for building a workforce with the right skills and knowledge for emergency care, designing and equipping simple resuscitation rooms and areas for the rapid assessment and management of the injured patient, implementing triage systems, trauma checklists and other clinical processes to improve safety and quality of care, collecting key data in order to understand the burden of injury and measure effectiveness of care, and establishing leadership, governance and financing frameworks to ensure cost effectiveness and accountability. Perhaps the most essential building block underpinning an emergency care system is the investment in the human resources and training. Building a workforce of doctors, nurses, paramedics, physician assistants and others will build a team of leaders who can drive the system's change required. Training providers gives clinicians the tools to save a life or prevent disability, but also empowers them to plan for and build an integrated emergency care system in their own contexts. Our experience at the Primary Trauma Care Foundation tells us that even a short clinical trauma care course like PTC can trigger a whole cascade of actions that improve the immediate care of the trauma patient and create better and more resilient systems of care from the scene to the hospital. Injuries occur everywhere, all the time. Safe and effective pre-hospital and facility-based emergency care saves lives and prevents disability for injured patients and also for all people of all ages with any acute or urgent health condition. Emergency care systems are an essential component and a cost-effective part of the solution for universal health access for all peoples with injury. And I'll end there. Thank you, Charles.
Thank you, Georgina. We have some questions already. Please, everybody, ask more if you wish using the Q&A box on your screen. And let me put to you, Georgina, the first one I've got here, which is, what is the difference between an emergency response in a disaster or a mass casualty event, and these emergency care systems that you have just been talking about?
Thanks, Charles. That's a great question, and an issue that many people get confused by. So what I'm talking about and what we're talking about is building up everyday systems of emergency care. Commonly, there's a lot of resources put into disaster response and a lot of energy. But if you don't have a robust and resilient everyday emergency care system, pre-hospital and at your hospital, then your resilience for those disaster events will be much lower. So we're talking about building up systems for everyday care, everyday injuries, or any other acute issue, which will increase resilience for the mass casualty events.
Okay, I've got a similar question. We see emergency departments and resuscitation rooms on television shows and they're full of expensive equipment and people doing advanced care. Isn't it too expensive to develop this in the LMICs?
So hopefully I've illustrated how building up an emergency care system does not have to be expensive at all. Training staff is not an expensive process, and the type of equipment that we're talking about, the type of resources that we're talking about are very basic things. Basic airway, breathing and circulation types of equipment. It's not expensive. It's about organising systems of care and embedding those processes like triage and other sorts of things which are don't require big expensive machines or high, beautiful, enormous resuscitation rooms. It's about organising systems, training staff, and putting in those very basic resources.
Thank you. Here's another question which I'm going to invite you, Georgina Phillips, to respond to, but also Dr. Mandip Kor. You've already spoken, but please be ready to answer if you wish. So the question is this: the negative consequences on health as well as financially of trauma are well known. Why is there such a gap, a huge gap, between evidence and what the healthcare staff says and what is actually done about it at a policy level? Who would like to answer that?
I mean, I think this is why we're running these kinds of webinars, Charles, because there is an enormous gap. I think there's a lack of understanding from policymakers and perhaps an assumption that the problem is so enormous and complex and so expensive. And yet what we're illustrating actually is the cost the cost to the country, the burden of injury is enormously expensive, and the investment in building up the systems to deal with it is actually not expensive. And if you build up your system of care, then you'll be addressing all sorts of other access, all sorts of other health issues that require a robust health system. Mandip, have you got anything to add to that?
Yeah, I think, acceptance and education, they come first, and, the resources and the money etc comes second. There are many organizations like PTCF. We do all the work on voluntary basis. There's no cost to the host country. If the country is willing to accept that there's a big issue that needs to be addressed, and they look into ways to address it, I'm sure there are many ways to get that addressed. There is a fund, there is a World Health Organization and other institutions which fund many other things like communicable diseases, etc. If that fund is asked for trauma prevention, I'm not saying trauma management, I'm saying trauma prevention as well, and that will only come after we accept that there is a big issue.
Thank you. I'm intrigued that our first two speakers have mentioned prevention quite a lot. So I think our fourth speaker in a few minutes' time will be more and more relevant. And there's a question came in we all might want to think about to answer later. It's on this line, and it is this: it is possible that we blame the trauma patients for trauma. I'm thinking, Mandip, that happens in India, doesn't it? Because of the lack of helmets when you're on 2 wheels, and the Indian Head Injuries Foundation campaign to try to address that. We put the blame on the trauma patient, and thus we don't take the needed steps to change the system. So maybe all of us at the end, if we have a moment, if we have time, we could address changing the system. But right now I want to go to our third speaker, and warm welcome to Dr. Abdul Basit El Sayed Ali, who is consultant and head of Department of Pediatric Surgery at King Saud Medical City, Riyadh in Saudi Arabia. He is associate professor in the Faculty of Medicine at the University of Khartoum, Sudan, and a graduate of that university, trained and worked in Sudan and also in the UK and Australia. He is co-founder and first convener of the Pediatric Surgery Specialty Council in the Sudan Medical Specialization Board, and EXCO member of the Pan-African Pediatric Surgical Association, which I think many of us might know as PAPSA, the Pediatric Surgical Association, Pan-African Pediatric Surgical Association. Abdul Basit is the trauma working group leader for PAPSA and the Global Initiative for Children's Surgery, GICS. So warm welcome, Dr. Abdul Basit. If I could see you, have we lost you on the screen? Oh dear.
There we are. Yep.
Anywhere?
Go ahead, Abdul Basit. We can hear you.
Yeah, okay.
Okay,
Thanks,
go ahead.
Charles. Thanks, Dan, Mandip, Georgina, and Nigel. Hello, everybody. And it's a great pleasure to take part in this session. I'm going to talk about in-hospital management of trauma. Trauma inclusion as a separate entity within the G4 signifies an attention to the importance of this still neglected health threat in many parts of the world, with significant disability, mortality, and socioeconomic implications. This talk will focus on in-hospital care for pediatric trauma. However, the situation in adult trauma care in LMICs is similar. The highest burden of injury is seen in LMICs, where 95% of all childhood injury deaths occur, with in-hospital mortality of about 1 to 2%. So in order to minimize and reduce the negative effects, good standards of in-hospital trauma care are required around the world, particularly in low and middle income countries. It is a high-tech kids problem, and whilst it's an established comprehensive service in the high-income countries, challenges in low and middle income countries are immense, leading to inadequate in-hospital provision of care for the injured children. It needs availability of trained medical and paramedical staff to deal with the children's trauma and within adequate facilities. If we take a quick look at the world's map of distribution of surgeons per population, it clearly shows the discrepancy that in LMICs, particularly in sub-Saharan Africa, there is 1 surgeon for every 1 million population, or in the best case scenarios, to for 100,000 population, compared to 1 for 1,000 or 1 for 3,000 population in high-income countries. The types of trauma for in-hospital management vary in nature and severity, including major trauma due to road traffic accident, fall from height, fall of heavy objects on the patients, resulting in multiple types of injuries: head and neck, trunk, limb, lacerations, injuries with fractures, and children in particular are also vulnerable to swallowing foreign objects, and they are also vulnerable to burns due to exposure to variable chemical, thermal, and electrical injuries. Patients are managed, therefore, by respective surgical specialties and subspecialties. Multiple trauma represents a particular challenge as it requires multidisciplinary interaction, coordination, and collaboration. So if we follow the patient's journey following reception and adequate resuscitation in an emergency department, a patient is shifted and the destination is decided following appropriate assessment. So based on the type of trauma and severity, stable patients may be shifted to the X-ray department for further diagnostic imaging or to the ward directly, while unstable patients may need to be shifted to the operating rooms or to the pediatric intensive care units. Therefore, diagnostic radiology role with imaging as simple as plain X-ray and ultrasound and as advanced as CT scan and MRI are necessary, not only to reveal the injury, but to determine its extent. Radiological facilities with intervention capacity can help save lives. So lack of facilities represent an obstacle and jeopardizes patients' care. Moving to operating rooms, functional OR facilities equipped with various but essential pieces of equipment are crucial for trauma care, including equipment for anesthesia and monitoring and many other standard requirements for any operating theater. The modern OR are equipped with hybrid facilities, and these are to accommodate standard and interventional procedures. While in contrast, looking at the bottom line pictures, lack of essential basic requirements, including even flooring, walling, ventilation, cleanliness, sterilization, lighting, and equipment and safety, all these are commonly observed in many low and middle income countries, consequently and adversely affecting the quality of service. In this regard, it is important to point out the encouragingly great charity initiatives to provide and install well-equipped operating rooms in low and middle income countries. An example is the bottom right picture of one of the kids OR operating rooms. For OR to function properly, well-trained theater staff is required, and bearing in mind that pediatric trauma represents a significant challenge to the anesthesia providers and to the surgeons alike. Moving to pediatric intensive care facilities, proper trauma service cannot be conducted without availability of ICU facility, which can significantly reduce the trauma-related mortality. PICU facilities require space, equipment, and highly trained medical, nursing, and technical staff. There is a marked difference between the ICU facility in a high-income country and low and middle-income countries, which further jeopardizes the chances for survival following major trauma in LMICs. Also, there is a need for allied specialties, blood bank, clinical pharmacy for production of TPN, laboratories, physiotherapy, and need for specialists in nutrition, education, rehabilitation, etc. There is also a need for registry, and that's for documentation of logistics and demand management, for auditing, KPI assessment, for research, coordination, development, and capacity building. There are many pediatric trauma initiatives. We in pediatric, the Global Initiative for Children's Surgery, believe that pediatric surgeons and all surgical subspecialties, we are all involved in children's trauma management one way or another, each within their capacity, ability, knowledge, level of training, and available resources and facilities, but unfortunately as fragmented services. We all care for children with trauma, but what most of us lack is to care for trauma care for children. In other words, care for system development and capacity building for appropriate children's trauma care. Pediatric trauma care is a no man's land. It's an orphan. Many children die every day, unfortunately because of potentially preventable or treatable trauma-related injuries. So what are the solutions? We believe that provision of fundamental requirements for an adequate, comprehensive pediatric trauma service within pediatric-friendly environment is a genuine and an urgent necessity. And the best way to achieving that is to get a group of pediatric surgeons or other concerned subspecialties to develop interest, enthusiasm, and ownership of the subject, which can be called a trauma ownership program or project, and they can gather and build a team of surgeons and paramedics with motivation and aptitude to run the service properly and to observe quality, integrated, and coordinated care pathways. Then they can move towards specialization and eventually develop trauma curriculum and specialties, as the case in high-income countries. And that eventually will lead to establishment of specialized trauma care centers. Thankfully, many organizations work in close collaboration through advocacy, both to public and healthcare providers, provision of adaptable training templates, and equipment to LMICs, and through encouraging development of local ownership to act with local authorities according to local needs and through locally available resources, utilizing networks for external assistance and collaboration. We have initiatives. It is also an utmost necessity that with the establishment of such health facilities, there is a need for a longitudinal program of collaboration for maintenance and training to ensure continuity and sustainability of the desired adequate quality services patients do need and deserve. So in summary, pediatric trauma, who cares? I think we all should care, as it is a major health threat with significant socioeconomic implications. There is a marked discrepancy and inequity in hospital services between HICs and LMICs. Top trauma ownership plan or project or program is recommended. The concerned NGOs' coordination, collaboration, and contribution are beneficial and highly appreciated. This is an opportunity to urge the United Nations, the WHO, the governments, the healthcare authorities, and community to exert efforts to prevent it or to mitigate its effects. And finally, ladies and gentlemen, there is a genuine need to draw attention of all stakeholders to the importance of proper training of healthcare workers and allocation of funds to hospitals and all healthcare facilities that provide pediatric trauma services to manage this non-discriminating but potentially avoidable, devastating, disabling, disfiguring, greatly distressing, and expensive health problem. Thank you very much.
Thank you, Abdel Basit. Let me put to you the first question I've received. In light of, I'm going to add this phrase, in light of the fact that you understand the low and middle income countries, and you've just now very well explained why we need to address the issue. But the question is coming about how. Here's the question. How can the authorities in the low and middle income countries establish quality trauma services for children? I'm guessing behind that question is the issue of budgets, for example, and equipment and facilities. How can the authorities in those countries establish quality trauma care for children?
Yeah, thanks for the question, Charles. This a big part of answer for that question is the budget. But before that, I think investment in children is investment for the future of every nation. And authorities can start with very, very simple things, like identifying the champions, those who can lead the work on the grounds, those who can lead the initiatives, and by identifying them and helping their activities, their movements, their plans, by helping them implementing those plans, gradually and supervising them, adopting them, training them to become like trainers for trainees and trainers for other trainers, and then fund them and provision of infrastructure and space for them, allowing them to have some freedom for movement to produce. So by so doing, authorities can help a lot. In addition, of course, to the role of authorities in providing the infrastructure and paving the roads, providing the ambulances. It's very unfair to see patients in low and middle income countries from remote areas being shifted in very awkward ways without ambulances for miles and miles to reach healthcare facilities following trauma. So that needs to be available for patients as close to their places as possible. And then they have to, of course, enforce the legislations and laws. And by law enforcement, a lot of things can be rectified in the cause of improving the situation with trauma. But fund is, of course, necessary.
Thank you. Thank you very much. Now I'm going to move on to our last speaker to make sure we don't miss him. And there will be time after he speaks to ask him questions and also general questions which have probably occurred to us all during the last three speakers. Just to recap on the questions we've received to Nigel and to all of us, I'll just repeat them. The global problem of preventable trauma is well known, but the ways and means to prevent, treat, and rehabilitate has not been addressed. Can you suggest some effective measures? That sounds like what Dr. Rossiter has been asked to do. Another question, similarly, could you please comment on the role of trauma systems in rehabilitation and long-term outcomes? Yeah, I just got a quick, no, that's good enough. That gives us a good start to help onto this last subject, which is prevention and rehabilitation. Let me just introduce Mr. Nigel Rossiter, who's a trauma and orthopedic surgeon in the UK. He's the chair of the Primary Trauma Care Foundation, past president of the Orthopedic Trauma Society, previous head of orthopedic trauma education in the UK and Ireland. He set up trauma networks in southern England, and he is an advisor to the UK's National Institute for Health and Care Excellence, which we commonly know as NICE. He has twice been voted Trainer of the Year and twice Inspiring Educator of the Year in the National Health System of the UK. And he's listed in Who's Who. He won the Hippocrates Award from Who's Who for excellence in the field of medicine. Nigel Rossiter, welcome.
Thank you, Charles. I'm not sure I deserve those, but anyway. Good day, as my Antipodean colleague would say, as we're in so many different time zones. I'm going to discuss the elephant in the room, the thing that we can all see. We all know that's there. We know about it, but we're not really wishing to discuss. So we're going to talk about prevention and rehabilitation. We can move on to the next slide, please. So we're all pretty familiar with these images. We all know there's a problem, particularly on two wheels in low middle income countries. And as Mandip has told us, 93% of all road deaths occur in these low middle income countries. And it really comes down to national legislation, looking at safety in and on those vehicles, the number of people in and on those vehicles, and the protection that is used, seat belts, helmet usage. But we need better roads. We need better understanding of the road usage and the laws around road usage. And we need national legislation to check vehicles to make sure they're safe to go on the roads. Inevitably, things happen, particularly on two wheels. And we really need much better legislation around this. But in high-income countries, in the last 10 years, design of vehicles has dramatically changed, and the laws surrounding the use of the safety parts of those vehicles has changed, and that's made a big difference. And unfortunately, as yet, This has been not yet been translated to low middle income countries. Now, 25 years ago, I worked in the United States, and my colleague Adam Starr and I were very interested to work out why there was such a dramatic difference between pelvic and acetabular fracture incidents in North America as compared to Europe. And actually, it's not just better roads, it comes down to road design. In North America, when you leave the freeways or the interstates, you tend to come to intersections. And at those intersections, the vehicle rarely slows down, and you get what are known as T-bone injuries. If you look at major roads in Europe, when you leave those roads, at most intersections, there are what we call roundabouts, or in North America, circles, where you're forced to slow down. And so the incidence of those fractures dramatically reduces. UN Resolution 7260 in 2016 is specifically designed to try and improve this situation in low middle income countries. And there was a UN Road Safety Fund set up in 2018, and last year the UN Road Safety Strategy. And all of these really need emphasizing to improve the situation. Next slide, please. As Mandip showed us, the next most common thing is violence and death from violence. And that accounts for 14% of all deaths. But actually, if you include suicide, that almost doubles to 27%. But not everyone dies, and there is a massive knock-on from the injuries sustained. And we need to maintain some perspective. There have been more deaths from murder than there have been from coronavirus in South Africa in recent times. There are 40,000 deaths a year from guns in the United States, half of which are from suicides, but there's more than 2.5 times this number in gun-related injuries. So when it comes to prevention, it really comes down to national laws and law abidance and legislation abidance to change our outlook to make things better. Next slide. Now, we in the health professions are not blameless. This image is not unfamiliar to those of us who've worked or come from low middle income countries. Overcrowding in hospitals is unfortunately all too common, and the lack of cleanliness and hygiene means that we have in-hospital morbidity from those people who come in to be treated from infections and the complications that ensue thereof. So we ourselves need to look at ourselves. Now, we've been talking about deaths, but deaths are really the tip of the iceberg. If you look at all communicable disease, that's malaria, TB, HIV/AIDS, and coronavirus deaths added together, they still are not as many as the deaths per year from injury. But there are more than 10 times that many people who survive who need hospital treatment. And over 100 times that many, as Mandip showed us, who actually are treated as outpatients. And all these people are not contributing to society. All of them need help. And if you put that into perspective, if you look at all deaths from communicable disease, they add up to just 3.5 days worth of injuries. So what happens to these people? Well, most people in low middle income countries just can't afford the standards of care that have been come to expect it in high income countries. There was a beautiful study done by the Vancouver group with Makerere University in Kampala in Uganda, looking at the outcome of lower limb trauma. And if you're a victim of a simple tibial fracture in Kampala, and as Mandip showed us, that's largely working age men, young men, and they may have up to 30 dependents a year dependent upon them. It takes them 18 to 24 months to get back to work. And within 6 months, all of their children are out of school and working to support their family. This image is all too common. He's unable to get around. He's unable to function. He's unable to earn. He has lack of self-esteem and he can't support himself, let alone his dependents. And he has become dependent upon society. Once he's medically stable, and what we see here might be what he's left with, he may never achieve anything physical function better than this. He needs really intensive therapy input early, not just physiotherapy, but actually much more importantly, occupational therapy, to be able to get him home so that he can sustain himself, he can get back to work or retrain for work. UN Article 26 stated that all parties need to take appropriate measures at the earliest possible stage. And what we see is not just a low middle income country problem. It affects every country in the world. Indeed, in my country, in the UK, rehabilitation has become the biggest issue. Indeed, the United Nations started as the United Nations Relief and Rehabilitation Administration in 1943 and was called that until 1946 to rehabilitate people after the Second World War. The WHO in 2017 set up Rehabilitation 2030 with 10 clear priorities to get people back to work. In fact, just 2 days ago, Dr. Jim Kim, the 12th president of the World Bank, told us that so far the World Bank has spent $6 trillion on coronavirus. And if we just spent a fraction of this on rehabilitation, we would actually achieve far more in getting people to be contributors to society again. So in summary, it comes down to two things. The most effective cure of any disease is to prevent it, and that comes down to national legislation and law abidance. And the most important thing is probably to get those injured people to be contributors to society again as soon as possible. And if we want to concentrate on one thing, this should probably be it. And it actually involves really very little money to be invested. Thank you.
Thank you, Nigel Rossiter, very much. Let me put a question to you. It's come in. You've just at the end there referred to rehabilitation. So the question I think is directed to people who are responsible for health systems in the low and middle income countries. I guess like ministers of health indeed. The question is, can you say briefly what are the interventions? What do we need to concentrate on to rehabilitate people?
It's not just low middle income countries. I think it comes down to almost every country in the world. There needs to be a way that we can deliver really concentrated rehabilitation to patients. Some way of patients going, let's say in a working week, Monday to Friday, to a centre where they're delivered really intensive therapy and retraining and occupational therapy over a 4 to 6 week period to get them to be contributors to society again. That model has been proven in the military in high income countries time and again, but we've yet to translate that to any other system in healthcare. And it's that system approach that we really need.
Thank you. Now with time running out, I want to put to all of us, see who can answer this, a beautiful question that just came in. This is a webinar in the context of the UN General Assembly. And here's the question. What actions by the UN would have the greatest impact on trauma deaths and morbidity worldwide? Here's your chance to speak to the UN.
So I think it comes down to two things. From my point of view, we already have some reasonably good systems in place to deal with the injured who are already picked up by the roadside and come into hospital. Abdul Basit has highlighted beautifully that in-hospital care needs some relatively minor investment, but it's systematic approach that needs to be approached there. But where the UN can really come in is pushing national legislators to make things better and safer in low middle income countries, and a very modest investment at the other end to get people back to be contributors to society in every country in the world will make a dramatic difference. But
Okay.
I'll see what others think.
Let's see what others think, and especially want to include Dr. Myron Rowley, who's joined us. I introduced you, Myron, before you came on screen, so that people have heard about you. Any others of our panel want to address that question? What would you like to say to the UN?
I'd like to encourage the UN to look at the resolution that was passed last year by the World Health Assembly. And there's been several resolutions that address road safety, road trauma, emergency care, and essential and emergency surgical care. And I think, you know, those resolutions really call on all countries to assess their systems, find out where the gaps are, and invest in building the systems of care across all of the journey of the patient, including the prevention and the rehabilitation. So I think it's really a call to action to look at the resolutions that have been passed and pay attention to them, and really take those steps that they're urged to take of assessing their own systems, finding the gaps, and prioritising the actions.
Right, thank you. Myron, anybody else want to speak to that question?
Yes, I'd say that the UN should engage and activate the younger generations as well, the millennials coming up on the pipeline, who will be, you know, your future leaders in this field, to make sure that they're activated, make sure they're enthused, make sure they understand policy, and that once all of you expert leaders are removed from the table, they're able to take on the mantle and do some wonderful things. I think it takes a collective effort and engaging younger folks who are ambitious and, as we see, just incredibly motivated once they latch on to you know, a cause. I think it will help tremendously. Thank you. Very apt comment, isn't it? Because after all, it's now the leading cause of death and disability in the ages 5 to 29. So those young people need the help. And what Dr. Raleigh is pointing out is the UN could motivate and use its younger people's voices in this. Yeah. I think the time has beaten us. I want to say that's all we have time for today. I want to say a big thank you to all of our panel members for your time and insights. Thank you, the audience, you watching this webinar, for joining us today. Thank you to our presenting sponsors for making it possible. We hope you will join us for the 4th and final webinar in this series, which is coming on Sunday, not tomorrow, but Sunday. The topic is Anaesthesia, Getting to the Tipping Point. And we will have another terrific panel ready to discuss that topic. And you can still register for it at the g4alliance.org. And we hope you will join us. Afterwards, recordings of all 4 webinars will be available at the same site. That's the g4alliance.org at SOTA Online. And the recordings will be available in English, Spanish, and French. So I want to thank the other 2 members of our organizing committee who helped us to put this webinar together. That's Nigel Rossiter and Myron Raleigh. And also our interpreters into Spanish and French, as well as the people at Lifebox who helped us to put together the interpretation into Spanish and French. On behalf of the 64 member organizations of the G4 Alliance, as well as the other sponsors today, thank you all for joining us, and goodbye.